السلام عليكم. صباح الخير. We're going to start a session about a very interesting topic in interventional radiology. It's relatively, it's not new. However, it's technologically and clinically it's having a very important impact in the recent years due to a lot of advances in the technology and imaging. It involves the MSK interventions, musculoskeletal interventions, divided into two major topics: tumors, benign and malignant tumors, as well as pain due to degenerative diseases. I'm honored to welcome Professor Dr. Nassef, head of the Interventional Radiology Department in Cairo University, and Professor Dr. Ahmed Abdurradi, who will be chairpersons of this session until the other chairpersons arrive. Our first topic will be by Professor Dr. Nassef, and it is entitled, "Could interventional radiology be a definitive treatment for benign bone lesions?"
Morning, everybody. We are going to speak about, could interventional radiology be a definitive treatment for benign bone tumor? And we need an answer by the end of the lecture. As we all know, for a long time, interventional radiology have been a great help in many aspects in the different parts and systems of the body. On the top of the list, definitely, is the musculoskeletal system. Starting from simple guided biopsy to guided injection, moving to preoperative embolization of tumors, all had been valuable procedures, adding for better outcomes for the patient. During the last decade, 3 decades, with the advances in the interventional radiology, the CT, the computer technology, the microcatheter, and the needles advances, opened the field for us to add another tools in the arsenal of interventional radiology. Let's start by aneurysmal bone cyst. ABC embolization could be, as we know, aneurysmal bone cyst treated by curettage, and filler, or even in block resection. In some locations, such as the pelvic bones or spine, the treatment is a real challenge due to many factors, such as difficult accessibility, significant intraoperative bleeding, and vulnerability of the acetabulum. Selective transcatheter arterial embolization is a good treatment option in this location. At first, we did this technique as a preoperative procedures to minimize blood loss, to give better visualization for the orthopedician for the treatment. Could it be a primary treatment, definitive treatment or not? We will see by ourselves. We started our series, and we published as a poster in the ESR in 2012, okay? Primary treatment of aneurysmal bone cysts in the pelvis by transcatheter arterial embolization as a definitive treatment. From 2004 to 2017, we encountered 23 patients with pathologically proven pelvic ABC, for which we did a definitive treatment only by transcatheter embolization, superselective transcatheter embolization of the feeding arteries. All the patients were discharged 24 hours after the procedure. Clinical and pelvic X-ray follow-up were done 6 weeks, 3 months, 6 months, and every 6 months. We have a mean 3-6 months follow-up for these 23 patients. The first case, 12-year-old girl with pelvic osteolytic lesion. We can see in the X-ray the lesion, taking the pubic rami, extending to the iliopubic ramus, taking the acetabulum. Sure, this will be much clearer in the CT, affecting the acetabular. This is the soft tissue window, the acetabulum and the periacetabular bones, clearly affecting the quadrilateral plate and both anterior and posterior column extending to the ischium in the bone window in the CT cuts. In the MRI, we can see the classical fluid leveling of the blood, the axial images, the coronal images. This will not omit taking a biopsy. Biopsy is a must, ample biopsy for every aneurysmal bone system to document the pathology. Okay, this is the coronal T1 before and after contrast, showing the enhancement of the wall, the active layer of the lesion. We will go for internal iliac artery, selective catheterization and imaging. We can see the blush of the lesion, selective catheterization and the embolization of the first superselective for the first branch. Then we move for the control, going to the second branch, embolize the second branch, and this is the post-embolization. We can compare the pre-embolization images, the pre with the blush, and the post-embolization images, as we can see here. Initial plain radiograph, this was the initial radiograph. This is 3 months and 18 months. We can see progressive sclerosis and ossification of the lesion with bone formation. Very nice outcome. Next, 7-year-old girl, right pelvic bone, aneurysmal bone cyst, also biopsy proven. The axial images by the MRI, classical fluid leveling. We will go, this is the external carotid. We do the internal. We didn't find tumoral supply and blush. This is the arteries mortis, is obturator, replace the obturator from the external iliac artery, giving this blush, significant blush. When we see such a blush, we know that the outcome will be great. So this is the pre-embolization. This is the post-embolization control images after embolization by BEVA particles. And we can see the difference very clear. This was the pre-embolization radiograph. This is 6 weeks and 9 months with progressive sclerosis and ossification. Another 17-year-old female, same picture affecting the pubic ramus, clearly seen in the MRI, fluid leveling, pre-embolization images, embolization images, after embolization, total deprive of the vanishing of the blush, the pre-embolization radiographs. This is 6 weeks and 18 months after the embolization. Another patient with selective left internal iliac artery angiogram, aneurysmal bone cyst. This was his CT images. This is just to compare. He was an athletic patient, and he needs to go to return his lifestyle. So we did a CT for this patient, progressive sclerosis and ossification. Let's move to a next entity. Osteomas account for about 13% of all benign tumors. Male predominance 4-1. Most of the affected are young in the teenager, 15% in the second decade. The most common symptom is bone pain, often worsened by night, dramatically relieved by aspirin and non-steroidal anti-inflammatory. The standard treatment was the traditional surgery. Due to the potentiality of complication of surgery, make the percutaneous radiofrequency ablation an attractive alternative procedure. Let's go rapidly. Classically, the osteoma is a circular ovoid nidus, okay? Within the sclerosis, the nidus is always less than 1.5 centimeter with variable degree of sclerosis. This sclerosis could mask the nidus. You cannot see the nidus within the cortex, but if you have such cortical sclerosis, you have to suspect for osteosteoma. The intramedullary and subperiosteal type, you have medullary sclerosis, and you find the nidus without significant. This make the diagnosis difficult and make also the surgery very difficult. You don't have the clue to go in and see the nidus. Computed tomography, CT, is the modality of choice for detection of osteosteoma. It provides best characterization for the nidus and also for the sclerosis. You can see the nidus here, and in 50% you will see the mineralization inside the nidus. So the nidus is the lytic lesion, and the mineralization is not a must. It's only present in about 50% of the patient. Magnetic resonance imaging, MRI, is not the modality of choice. In T1, it might appear as isotense to the muscle, as you can see here. In T2, it gives a variable from bright to iso, okay? The surrounding reactive zone will display edema, non-specific edema pattern, as we see here, okay? When we see this edema, non-specific edema pattern, we should go for CT to declare the nidus. Surgical management, the success rate is from 88% to from 88 to 97%. It always leaves a bone defect, and the localization in many cases will not be that accurate. You might be unlucky to need a surgery, such this patient. He removed nearly half the cortex and left the nidus in place. Surgical management could impair the bone growth or causing affect joint mobility. In such patient, what to do? Surgical procedure for this supraacetabular iliac bone. The average operative hospital stay from 3 to 5 days. Weight bearing will be affected 1 to 6 months. Crutches may be necessary in the lower limbs. For osteosteoma, the use started by 1989. Initial results were reported in 1992. We started the technique in the year of 2002, our first experience. The procedure should be done under general spinal anesthesia. Local anesthesia will lead to insufficient control of pain. This is not recommended to do the technique under local anesthesia. Clinical success regarding the RF, the absence of pain for at least 2 years between this result in about 90% to 95%. Recently, we increased our results up to 98%. The average procedure time, 90 minutes. The duration of post-care from 3 to 24 hours. We don't need any cast, splint, or external support devices. So it has a great acceptance during these last 2 decades. It moved from, it became the corner and the golden standard. It moved us from the classical cases in the different part of the body. We will go to wide varieties of challenges, such as the tiny lesions, not easily to be visualized, not easily to be anchored, such this small lesion, which is hardly seen here, and small lesions, it appear here in the bone scan, targeted by the needle, and this is the post-RF results. Large lesions, you might need to have longer probes or 2 times intervention by overlapping zones, such in this patient. We give the first and the second, and we have 2 tracks in the post technique. This nidus with about 2 centimeter or 2.2 centimeter in diameter. If you have a closed short axis, you always choose the shortest axis with the least complication, be away from the neurovascular bundle. So in such a small lesion, the better will be this, but this cannot be accessed because the vulva is here and the perineum, it's not an easy access for this. So you might try this. This is the femoral artery and vein. So the solution will be just to go from the other side, hitting the nidus from the lateral or anterolateral approach. In extensive sclerosis, there is two solutions. Either you go by a power drill firstly, and then go by your needle to the nidus, or you can use a similar trick. If you go for this sclerosis dense with cortical thickening, you can just go from the opposite cortex and hit the nidus. Juxta-articular lesion. Could anyone imagine what a surgeon could do for such medially located in the femoral neck within the capsule, juxta-articular, but easily it could be done by this axis, and this is the post-RFA images. If you have a lesion just like this from the intra-articular, it is within the head, small size, but it will be very, very challenging for any surgery, but for RF, you can easily access the nidus, and this is the post without any complication. You have to see this is within the head, and the acetabulum is affecting, and the anterior column is going. So what to do? You have to go for external rotation of the head, and you can hit the lesion nicely. If you have in case of nearby nerves, just the site of the common peroneal nerve here, okay? If you want short access, you will injure the peroneal nerve, so it's better to go from the other contralateral side, and this is the post-ablation track. Spinal osteoblastoma account for about 10% of the outcomes. Involving of the posterior element is more common than the anterior part. Classical manifestation of spinal osteoma is the painful scoliosis, the well-known painful scoliosis. Obstacles include the closed axis, the facet joint, and the neural foramina with the nearby nerve. But in some cases, we have many clues. This osteoma in the lumbar vertebrae with the mineralization dense for a 14 years girl. You can go extralateral extended approach, and you can reach the nidus, leave your needle, and complete your ablation. You're making the tumor just like a button. Cervical spine, okay, posterior element, you can hit the lesion going inside and finish without any complication. Intraspinal, this is a very critical C4 lesion, C5 lesion, with nearly no cortex between the cord and neural tissue and the nidus, but you could hit it from the posterior. Be aware that the vertebral artery is here, and you finished without any complication. This is the second day. You can see the ablation, the entry site. But you might be unlucky, just like this girl, 7 years, with 7 months duration, severe pain, worsened by night, relieved by analgesics, spastic neck, torticollis, and no motor deficit. This lesion in C2, in the anterior mass, close relation to the dura and to the spinal cord. You can see in the MRI how close the lesion with the contacts with the dural surface. This was our needle entry site. First, we took a biopsy, and then we introduced our RF needle going by another spinal needle gauge 20. We inject, by this time, we don't have carbon like site to be implemented. We put some room air to separate the dura and the spinal cord. You can see the tip of the needle, the dura. There is inadvertent some air in the retrospinal muscles. This is 2 days after the procedure. The entry side, the patient can move her hands, and the mother in the background is very happy by the result. This is 3 months after the RF ablation. This was in January 2014. This is before, and this is with the after the osteoblast ablation for this patient. So, in different locations, including the spine and some of the atypical location. So, could intervention radiology be a definitive treatment for the benign bone tumor? What do you think will be the answer? Yes or no? No one is here. I think it's yes. The answer is very clear. Yes. Thank you so much. Only 16 minutes.
Thank you, Dr.